Top Med Talk.
Well, hello, I'm Desiree Chappell, and this is Top Med Talk. We're coming to you with coverage of the COVID crisis from the front lines. Now, we've had conversations with care providers all over the world who are either on the ground themselves or they're playing a more supportive role in the battle against coronavirus. We're going to continue to share those stories in hopes to provide education and support to all the healthcare workers out there everywhere caring for COVID patients. Now, today I'm joined by our editor-in-chief, critical care doctor there in London, England, Monty Mythen. Hello, Monty.
Hi, Desiree. How are you today?
I'm doing very well. Thank you very much. How are you doing? I know that you have been in and out of the hospital, kind of trying to get a feel for what's happening on the ground.
I haven't been into the main hospital today. We have virtual ward rounds. We shouldn't really call it that. They're real ward rounds every day, but using this sort of technology that we're talking on at the moment and looking at things together via video links. I'm feeling just a little bit down right at the moment because although we've taken, we think, the heat out of the COVID crisis, as we've been calling it in London, that we get the impression that the surge is starting to plateau. The government's just announced that there's probably going to be another 3 weeks of lockdown here. Now, that story will mature over the evening. It's already 7 o'clock in the evening here as we're recording this. So there'll be a lot on the news about that tonight. So that's a mixed message, feeling at the sharp end for my colleagues who are dealing this every day of the week that there might be taking, to flatten that curve a little bit we keep talking about. But for the broader community, a message to handle another 3 weeks of lockdown.
Well, hopefully they're going to be able to kind of clarify that in the days to come. I think we are kind of getting some of the same messages here in the U.S. And for a U.S. perspective, we're going to be talking to our next guest who comes to us from Northeast Philadelphia. She's a critical care nurse with 29 years of experience in working in a medical ICU with COVID critically ill patients. Kathy Crawford. Kathy, thank you so much for joining us. I know you're extremely busy, so thank you first to the dedication to your patients, but thank you for taking the time to chat with us on Top Med Talk.
Thank you for having me. Honored to be here.
Can you give us an idea of what it looks like for you in Philadelphia and what your facility looks like?
My facility is outside of Philadelphia. We are a large teaching hospital, level 1 trauma center. I currently work in a 24-bed medical ICU, and we have turned into an all COVID unit. My healthcare system has multiple ICUs, and I am also part of the rapid response team. So I am at times going out to different areas of my hospital to take care of COVID positive patients, a person under investigation, and of course, non-COVID patients.
Kathy, I've been hearing that the heat was starting to get turned up there in Philadelphia. Is that because I know other parts of Pennsylvania may not be feeling it quite like you are there?
They're predicting the surge this week or next week. And we're certainly looking to our colleagues in New York City and seeing what's happening there. And we're very hopeful that we have started to flatten the curve out here and perhaps gotten ahead of it because I know that they are really struggling up there in New York City from what I'm reading.
Yeah, absolutely. Well, Kathy, can you speak to what's happening there in your medical ICU? You said that you have a 24-bed now dedicated specifically for COVID patients. Can you talk about staffing? Are you guys being able to staff everything with the critical care nurses and physicians that you currently have, or you had to do any upskilling there in your area?
Yeah. So we are very fortunate. We've added a couple physicians to our team and resident staff. And as far as ICU nurses, we still have critical care nurses that are able to take care of the patients. We also have nurses from other areas that have been furloughed because we've canceled our elective surgeries, and they're coming in as kind of runners to help us. Our doors are closed when we're in the rooms, so they're able to get things for us and also don and doff and come in the room to help assist us with care. So I'm very fortunate with staffing at my facility at this time.
Have you done any sort of back to the basic training for any of those people that are in those supportive roles, or even for your staff in taking care of the COVID patient?
Like I said, we haven't had the surge in our area as of yet, but we do have a plan where I think that has been looked at if we needed to. What we are seeing currently, I just worked 2 night shifts this week, is a lot of CSLED or continual dialysis therapy, or at least for 10 hours. We're doing a lot more CSLED than we have in the past because it has shown to improve some outcomes. So we're looking at how we can pair non-SLED trained nurses with trained nurses in order to care for these patients, which is something we haven't done in the past.
talk a little bit about, the basics of caring for them, because Monty and I can attest to this, everything that we've been hearing that's been coming out and everyone that we've been talking to, things have changed quite a bit in the last month or so. Well, they're presenting the same way, but how we're taking care of them. Can you speak to that a little bit?
I can, at least from the perspective of when they come up to the medical ICU. I think initially, when we started with this several weeks ago, we kind of were under the impression that we were going to intubate early. And we saw that a little bit more. Maybe we didn't try non-invasive ventilation as much as we are now. Now we are tolerating patients on high-flow nasal cannula with lower oxygen saturations than we have in the past. And we're trying to avoid intubation if we can, if we feel like that's a safe avenue for the patient. We are also doing non-invasive ventilation. We are proning patients that are on high-flow nasal cannula, which is something, so we're just asking patients to turn over on their stomach, basically, which is something that I've never done before. So I think that is one thing that we're seeing. And you mentioned it so well. It changes almost weekly, if not more.
Kathy, that's very much been our experience in London. So there was a lot of discussion early on about early intubation versus pushing the use of high flow oxygen and non-invasive ventilation. And I think if we were starting all over again tomorrow, we would do as you have decided as well. We're seeing this very much as a severe viral pneumonitis, of which some people seem to be very susceptible to it. There's lots of other stuff going on as well, but it's certainly not like a classical sepsis. And therefore, everything we can do to try and keep the patients off the ventilator seems to be in their best interest, and or that's them selecting themselves out for a better outcome. And that, the proning of the non-intubated patient, we're seeing a lot of, and we hadn't seen a lot of that before. So agreeing with everything you're saying.
I'm glad you guys are doing the same thing. Like I said, it's very interesting, and it's almost a full-time job keeping up with all the changes sometimes.
Yeah, absolutely.
Kathy, another thing I'd say on that is, because we had a big reflection on all of this today, because we're quite a long way into it, is that playing, as we always would do every day of the week, playing what's in front of you, if you see what I mean, is probably the best approach to it. Working off rumours about wet, dry, what you do with the lungs, early, late intubation, PEEP levels. We're all very, very experienced at doing this. Play what's in front of you.
Yeah.
Yes, it's interesting. Someone just shared an article with me, published, looks like by Gattinoni. You probably are familiar with it, about type L and type H COVID. And unfortunately, I haven't really had a time to read it all and let it sink in, but just different ways to ventilate these patients. So I think it looks like it came out of probably Italy, would be my guess.
Yeah. Luciano Gattinoni is a legendary Italian ARDS specialist doctor.
I'm actually very excited about reading that later this afternoon.
Can you tell me, has that some of the, this high flow oxygen proning patients, is that challenging in its own way? I mean, are you facing some new challenges with some of these different approaches?
Yeah, no, I would not say it's been easy. I think the challenge is we're limiting the number of staff that are going in the rooms. We're trying to limit exposure and, of course, conserve PPE. Anyone who's been watching the news knows that that's a huge concern here in the United States. What kind of mask, what kind of PPE people are wearing. So I'm in the rooms by myself, and some of my patients who are on high-flow nasal cannula are alert and oriented, and some of them are older and suffering from dementia, and I'm not able to explain things, or I am able to explain things, they just don't understand them. So I think that is the most challenging part. As critical care nurses, we're used to running back and forth between our 2-patient assignment, which is what I currently have, and having to really think about the care that I'm going to do, go in the room and be in the room for half hour, 45 minutes, hour and a half, whatever it looks like, depending on what I'm doing. That has really changed the way we're approaching care. I think that's the greatest change. And also the process of donning and doffing, when I have a 2-patient assignment in a 12-hour shift, it's truly exhausting. And I guess I never really thought it would be until I experienced it.
Yeah, you don't appreciate that because, in the past, I was a critical care nurse myself. You don and you doff if you have somebody that's, has an MRSA or something like that. But this is just different. It just feels different. And you're having to live in that constant pressure of taking it off and doing it exceptionally well, which is, I don't think that we all did that before.
One of the biggest, we're seeing a lot of it already, and some of it's happened in other parts of the world because they're more familiar with having these epidemic situations. I think one of the biggest innovations we'll see is in better technology to enable us to don and doff without going through this sort of, it just seems archaic. It's like putting on medieval armor. I know it's not heavyweight, but you know what I mean, Kathy? It's kind of, you know, you kind of think, come on, you know, we've got to have a better way of doing this.
I agree. And, you know, maybe after this is all said and done and when we've all become experts in the donning and doffing of PPE, you know, our hope is that maybe we see a decrease in other hospital-acquired infections because we're doing a better job at this. So, but yes.
That's definitely a silver lining of this whole thing.
I like to think there's something.
Yeah. Well, Kathy, moving on from, you know, the managing their airway and things like that. When it comes to ventilating the patient, so you have a patient that now has escalated and requiring ventilation. Can you tell us a little bit about how you're ventilating? Because, you know, it all started out as these are ARDS, you know, high PEEP and lots of pressure to backing off of that and easing off of that. So is that something that you guys have done there, or how do you ventilate your patients typically?
Well, I think that's a hard question to answer. It really does depend on the patient. The one thing that I'm seeing differently with the COVID patients is the ones that do decline very rapidly. You know, sometimes they are coming up from the ER and we're quickly intubating them, having a hard time ventilating them, and moving on to paralytics in some instances. We are adjusting their PEEP using this esophageal probe, which is something new in my ICU. We've only used this maybe for a couple months. I'm sure Mython could expand on the science behind that. But I'm seeing some patients with higher PEEPs than I normally would in an effort to ventilate them. And that may just be because we're new to the technology using this esophageal probe. I think that is one difference. And I think a lot of our patients, we're seeing AC, our traditional settings of AC. We're still seeing lower tidal volumes, but we're starting to play a little bit with this new study that was published between the different types of COVID. And I think next week it might change.
Yeah, that's probably a given.
I think, Kathy, again, I think there's a lot of debate going on in various different areas about, is this ARDS, isn't this ARDS? We have to remind ourselves that, you know, the definition of ARDS, you know, it's a syndrome that is it's acute, it's not cardiogenic, it's a low PaO2 despite a high FiO2, and it's bilateral pulmonary infiltrates. Now, the debate here is whether the lungs are stiff or whether the lungs are not stiff. Right. And I think people are possibly getting themselves a bit too bent out of shape about having major discussions about is it or isn't it ARDS and should we use the ARDSNet protocol. We should use the ARDSNet protocol if it's appropriate for the patient in front of us. Again, hence the comment about we're all very experienced. Let's play heads up intensive care, critical care.
Yes, I think I agree. And I have to say we're having a lot more discussion outside of the room with the intensivist, with the resident staff, the respiratory therapist, and the nurse before I go in. Kind of, you know, what's the plan here? You know, they're dropping their oxygen saturation. What are we going to do? I do like that discussion. I feel as a critical care nurse, I'm a lot more involved in that, and I appreciate having that input.
And it is, as you said, the consensus now very much seems to be that this is a very severe viral pneumonitis, and it's very much more respiratory intensive care. I say that as not, I'm a general intensivist with a broad previous experience. This does seem to be very much about the lungs with the secondary collateral damage to other organs, as opposed to the sepsis we've got used to in recent years, which is very much multi-organ.
Right. And I think we do see a lot of acute kidney injury.
Absolutely.
And a lot of these patients, of course, may have a history of diabetes and may have some underlying chronic kidney disease to begin with, but that seems to be a risk factor for patients that are becoming more acutely ill as well.
So again, the chatter there's been hosted a global conversation by our Intensive Care Society and a few other global organizations. And if you look through that, there's no great consensus about what definitely to do, but there does seem to be a global consensus about what not to do. And on the acute kidney injury front, it is, we've had a recent tendency in recent years to go dry for the lungs, or some people have. They've said, hang on a second, your first duty is to resuscitate, and then to replace, and then to remember to hydrate. And we get the impression that our demand on hemofiltration has dropped off quite significantly in the last few weeks in London. Possibly just because we've, as again, not worked on rumours, but played what's in front of us.
Yeah, and I think using some hemodynamic parameters, to determine what kind of fluid a patient needs is certainly very helpful in this situation. Because they should really be, euvolemic. I don't know that we want to keep them, like you said, too dry.
Well, that's what I was going to ask you about, Kathy, is, moving on from ventilation. What are ways in which you guys are employing to manage their hemodynamics? And are you tending more towards the drier side, and restricting fluids? Has that been something that's been a process, a changing process throughout the last several weeks?
Yeah, I would say that it's been a changing process throughout the last several weeks. I think initially we wanted to keep the patients dry, and I certainly do have some patients that I'm giving Lasix to. I think we are looking at the patient that's in front of us. I will say that a lot of patients are requiring pressors, and I have had patients on esmolol drips and dopamine drips, which is something that I haven't used recently for a variety of different reasons. So I think if we look at our hemodynamic parameters to help us kind of to guide care, I'd like to see us doing more of that, if I'm being honest. Kind of getting a little bit more information. Because if you've got a decreased compliance with the lungs, or you're having a hard time ventilating, it's got to be affecting the right side of the heart. And so that kind of brings into question, if they have an underlying cardiac condition, how can we optimize them better? And I don't know the answer to that.
Absolutely. Kathy, I think it's taken us back to the decades before, when seeing a primary acute lung injury seemed to be much more common in the original early days of the description of ARDS, which I'm pretty much old enough to have lived through. Is that when we're looking after the lungs as the primary organ that has gone down, our objective is to generate oxygen delivery as part of the whole system. It's not to just generate a PaO2.
Correct.
And therefore, airway, breathing, circulation. It's a nasty disease. The challenges are very much in the logistics and the numbers of the patients. But I think once you're into it a little bit, it's airway, breathing, circulation.
I would have to agree with that. And like I said, it changes. It changes every week.
Yeah.
And we're up for the challenge.
Kathy, would you say that you have had to do some kind of back to the basics? I mentioned this before, but, training when it comes to, hemodynamic management of these patients? I mean, you said you're using dopamine and some other things. Are you constantly re-educating everybody, or what do you feel like is happening there?
As someone who's been in critical care for some time, I do get a lot of questions, and there is some re-education and explaining what different drug drips do, explaining how to adequately paralyze a patient, using the train of 4, using the BIS monitor, why we are sedating them. I feel that, in critical care, at least in the United States, we have a lot of new critical care nurses, which is wonderful because they're all like sponges. For those of us who have been in critical care for a while, we certainly are doing a lot of in-the-moment teaching. I work the night shift, so our resources are less on the night shift in terms of educators and things like that. So I do know that one of our nurses is creating a laminated sheet for the C-SLED. Because like I said, we're starting to see it more, particularly in my unit, and we're trying to get more independent with that and trying to, like I said, limit the number of times we go in the room. So we're starting to see a lot of these homemade things creeping up in my hospital. And we're fortunate that we're a large teaching hospital and we do have a lot of resources available to us that have been there all along.
It's so important, I think, Kathy, for people to hear about experiences like yours, because we have a lot of listeners that are frontline workers themselves. But we have a lot of people who might be waiting in the wings to start taking care of patients. Hopefully we don't see a surge, but they may not be critical. They may not, like in the case of a CRNA, we may not have worked in a critical care unit for years. There may be some physicians that are, not critical care physicians, but may have to go back in. And so do you have, top 3 tips of what we need to consider coming in as a non-critical care, routine critical care provider?
That's a great question. I think I would like to see, if someone's new to critical care, being paired with someone who's experienced, if you're in a physician, being paired with a mentor, an experienced physician. I do hear our physicians talking to the residents who maybe haven't been familiar with critical care or haven't been in there in a while, kind of giving them the top tips about ventilation and sedation, I think is important. Mm-hmm. And for critical care nurses, about the different medicines you're likely to see. Levophed. We're running into drug shortages in the United States. So we're starting to use PO or down the OG tube, oxycodone, and trying to lighten maybe a little bit with the fentanyl. We're starting to use IV Dilaudid, which is something we haven't used in a while. So I would definitely go over different medications that you would expect to see at the bedside that have to do with sedation, vasopressors, cistatracurium, or whatever paralytic agent you're using.
Yeah, it's been a while because I know that it was in fashion whenever I was a critical care nurse, but I think it kind of fell out of fashion to keep people paralyzed on the vent.
And the train of four. And then arterial lines. A lot of our patients are, the ones that are obviously critically ill are getting central lines and arterial lines. And just how to set up your central line system. We all have a way we like to put all the pressors into one lumen, how to manage an arterial line, how to manage a CVP, if that's something that your providers are wanting to use. Those are some tips and tricks. And then, to really make sure that the nurses are the ones that are going into the room taking care of these patients. I mentioned how exhausting it is physically, but it's also emotionally exhausting. In my facility, we are not allowing COVID patients to have visitors. Actually, there's no visitors allowed in the ICU. So this is something very challenging for us to communicate. I've gone into the room with my phone and I put it on speaker so family members can talk to their loved one, whether they're on high flow nasal cannula or intubated. And I'm part of such a private conversation that normally I would give families a moment and step outside of the room. And it's very tearful. And, I think that emotional toll is something that needs to be recognized in our frontline staff, for nurses, physicians, respiratory therapists, all of us that are in these rooms. It's hard. I've never had to experience this before in my 29 years.
Kathy, if you don't mind me asking, how are you dealing with it personally? Is that something that you can share or that your hospital is providing any type of support, or maybe not hospital is the right word, but each other?
Yes, I'm fortunate that I work in a wonderful intensive care unit and I have over 90 nurses, and we are very supportive of each other. And me personally, I exercise a lot. So
yeah.
It is good. I do a lot of running and I ride a Peloton, actually. That's actually been a source of stress relief for me. And I just try to get outside with my dog. And I have socially distanced myself from my family. My husband is an asthmatic, so I do worry about him contracting this from me. And I have 4 children. So I stay in a part of the house where they're not. So that's a little bit hard. I'm not going to lie. But I feel that it's important that I keep my family safe.
Yeah. And I can tell you, I'm sure that you hear this reported by anyone you hear that's working on the front lines like yourself, that is the big challenge. I think all of us are prepared to go in sometimes and do the challenge at work, and deal with the things that confront us there. But when we have to really be concerned about taking all of this home, and how that would impact us at home, I think has been a huge burden, I think, for you guys to have to carry.
I've lived through many different infectious diseases, starting with AIDS in the late 80s and early 90s. And certainly I was part of an Ebola response team at my hospital. So I'm not afraid to take care of infectious diseases, but I need to feel safe and I need to know that my family's safe. And I think that resonates with all of us on the front lines.
Yeah, absolutely. Well, Kathy, thank you so much for this wonderful conversation. Again, it just provides so much support and enlightenment for kind of what truly is happening on the ground. And I think our listeners can relate to what you're going through. And it's nice to hear that, you're not the only one out there. So we really appreciate the time that you've taken with us. And hopefully we can check back with you again to see how you are and how you're faring in the weeks and months ahead. Because it sounds like it's going to be around for a while. Is that kind of what you guys are preparing for?
Yes. In the state of Pennsylvania, I think they just instituted or planning on institute, anybody who goes out in public needs to wear a mask. So, and I think that is also true in Maryland as well, a neighboring state. So we're starting to get the idea that this isn't going to go away in the next week or so. So yes. And thank you for having me. I was honored to be asked to be here, and my heart goes out to everyone who's on the front lines. And I hope everybody stays safe.
Great to talk to you. Good luck, Kathy. Good luck.
Yes.
Yes. Well, good luck as you go forward with all that you're doing to support your colleagues there and with the, the education and being a resource for them. It's so important to have people who've been doing this, been around a while and been around the block, because I'm sure I can't imagine being a new nurse and not having someone like you to help, guide me through this. So what you're doing is incredible. So keep it up.
Thank you so much. Thank you so much for having me.
All right.
Top Med Talk.
Well, thank you so much for listening to the series COVID from the Front Lines. You can find more of this at topmedtalk.com and by following us on your favorite social media platform. Stay safe, stay well, and we are going to get through this together. So thanks for listening.
Top Med Talk is proud to thank its sponsors, specifically Edwards Life Sciences, for their generous support through this global crisis.